Hi, I'm Kristen Hodgson, an IVF mom, proud women's health advocate, and co-founder of Rescripted. Welcome to From First Period to Last Period, a science-backed health and wellness podcast dedicated to shining a light on all of the women's health topics that have long been considered taboo. From UTIs to endometriosis, we're amplifying women's needs and voices because we know there's so much more to the female experience than what happens at the doctor's office. With From First Period to Last Period, we're doing the legwork on your whole body so you can be the expert in you. Now let's dive in. When it comes to our reproductive health, hindsight is often 20/20. But in a world where it takes an average of 7 to 10 years to be diagnosed with endometriosis, it's high time for reproductive health care that's proactive versus reactive. In this 4-episode mini-season of From First Period to Last Period, I sit down with fertility specialists at the Oncofertility group to discuss how uterine fibroids disproportionately affect Black women, why surgery for endometriosis shouldn't only be considered as a last resort, who should get a mammogram before trying to get pregnant, and why your fertility clinic should be searching for the root cause of your fertility issues. Visit CoFenusFertility.com to learn more. Hi, everyone, and welcome back to From First Period to Last Period. I'm your host, Kristen, and I'm here today with Dr. Jason Kofinas. Hi, Dr. Kofinas.
Hi, Kristen. Thanks so much for having me.
Absolutely. So for those of you who don't know Dr. Kofinas, he's a reproductive endocrinologist and infertility specialist, as well as the director of IVF and research at the Kofinas Fertility Group in New York City. So welcome. I'm so excited to have you and to talk all about preventative gynecological health, breast health, and oncofertility today.
Thank you, Kristen. Yeah, this is a great topic. And I think one that we don't focus on as much. So I think it will be really nice to talk about this for your listeners. And I think it will be great.
Yeah, absolutely. And this month at Rescripted we're all about preventative health and telling people how often they should be getting their pap smears and mammograms and self-breast exams. And I think, especially when you're going through fertility treatments for a long time, I've been there, I still am there. You can be so focused on it that you sometimes forget like the annual wellness checks and all of the other health and wellness preventative stuff that you need to be doing. So we're here to remind everyone that you still have to go for your annual physical, get your pap smears, mammograms, etc.
Yeah, I agree. I think you can get really into the whole process and forget that there are basic health maintenance things that should be done that you don't really want to run into trouble with while you're pregnant. So this is an important topic and one that a lot of fertility doctors ignore or don't want to deal with, which is not great, obviously. So I think empowering our own patients also to really think about that on their own terms and to ask the right questions, I think will be valuable.
Absolutely. When you have a patient come to you for an initial consultation, or do you bring this up? Are you up to date with your annual OBGYN visit, or have you had a pap smear? How do you check that box?
Yeah, so it's part of our initial intake. So we want to know when the last pap smear was, how long ago it was, what was the results, have there ever been any abnormal results? If yes, how were those handled? How long ago was the abnormal result? So we try to go into detail because it does make a difference in terms of recommendations for when another pap smear should be done or how often screening should be done. Similarly to a mammogram, obviously there are recommendations for when mammograms should start, but those can really depend on family history, clinical breast exam, prior mammograms, making sure that the patient knows where they fall on their routine screening and or do they need to be a little bit more aggressive with their screening before starting this process?
Absolutely. And actually putting the cart before the horse a little bit, but what exactly is a pap smear? Because I think a lot of women think it's an STI test and that's not the case. It's a very important distinction. So can you just quickly go into what a pap smear is exactly?
Yeah, in many ways, component of it is an STI test, right? HPV is sexually transmitted, and abnormal pap smears and ultimately cervical cancer really come from those high-risk HPV viruses. So a pap smear, kind of in its basic form, is a test that allows cells that are in the surface of the cervix and on the inside of the cervix to be tested for any abnormalities in terms of how they look. And then those abnormalities can then be graded from less severe to more severe. And also at the same time, HPV status is tested. And based on the results, either further investigation needs to happen, or you return a year later for a screening, or in many cases now, if a pap smear is completely normal, including a negative HPV, recommendations are pushing repeat pap smears from 3 to 5 years later.
Oh, wow. I didn't realize that. Yeah, I think you go to the gynecologist every year, but sometimes they're in there anyway. So you're like forgetting how often you actually go have them do the pap smear. But
right, we don't even know necessarily if they did one. And I can't tell you how many times patients tell me, I think I had a pap smear. I'm like, why don't you call your gynecologist and get the records and I'll take a look at it. But I also think it's important that just because the pap smear is every 3 years, that doesn't mean you shouldn't go to the gynecologist every year. Those recommendations of going to the doctor every year still are there, whether or not you're getting a pap smear. And a lot of women really use their gynecologist as their primary care doctor. So if they're not going every year, they're not seeing a doctor every year. And that's not really good preventative care.
That's a really good point. I feel like it's only been a couple of years now that I've actually had like a general practitioner, but for a while there, I was just going to my OBGYN.
Yeah. And the OBGYN is your front line. You're looking at things like fertility and things that can impact fertility outcomes. Some of the things that you would tell your gynecologist are things that could actually give clues to why you're having trouble getting pregnant or why you're having trouble keeping a pregnancy. So things like heavy bleeding, abnormal bleeding, pelvic pain, there are conditions that those specific symptoms can clue you in on that if you don't go to a doctor or tell someone, you will never know and you won't actually pursue that.
Yeah, absolutely. And does age kind of factor into this at all? Or are the guidelines pretty standard across the board?
Yeah, really the big one's 30. So when you're under 30, if you have HPV, typically the follow-up is less aggressive because you tend to clear the HPV on your own. If you're over 30 and you have HPV, the rate of clearance is lower. So they're following you a little closer. And there's a lower threshold for doing things like a colposcopy, for example, where you're examining the cervix under a microscope and maybe taking a sample of an area that's a little suspicious. And then from there, based on those results, hopefully you don't need this, but sometimes you have to go a little bit more aggressive where you might need to do what we call a leap, which is a procedure that takes a piece of the cervix that the abnormality is located, or you think it's located in. You take a piece of the cervix a little wider than where the abnormality is to make sure that you remove any sort of precancerous cells. And that is typically curative, right? But if you think about the flip side of that, you are taking a piece of the cervix. So there's pluses and minuses. And the thing about cervical cancer and HPV and abnormal pap smears is that from the time you have an abnormal pap smear or positive HPV, the time from that to full-blown cervical cancer tends to be years. That's where the idea of spreading out the screening and being a little more conservative came from.
Oh, okay. Interesting. Yeah, we wrote an article not too long ago about the LEAP procedure, and that was the first time I had even heard of it. Obviously, it's a good thing if you don't know about it, because it means you probably haven't had an abnormal pap smear. But at the same time, I just never even knew what you do when you did have an abnormal pap smear.
And even for doctors, the guidelines can be extremely confusing because there's a lot of kind of gray zones sometimes, and you tend to move towards further testing rather than being too conservative either, because you don't want to miss something.
Yep.
But the nice thing about that is that the actual progression to a big problem like a cervical cancer tends to be slow.
Okay. And I feel like it's not talked about enough, but ovarian cancer, there's not really a screening for that, correct?
Yeah. So they've tried, there's papers that have come out that you do ovarian ultrasounds and there are markers for ovarian cancer. But as far as I know, there really isn't any kind of benefit to screening with an ultrasound over and over again. You might catch an ovarian cyst, and whether or not that leads to a diagnosis from there it's not a very sensitive tool for ovarian cancer. And that's really the biggest problem with ovarian cancer is diagnosis tends to come when it's already spread. And that's why it's such a serious cancer and why it is so deadly.
Yeah, quick aside, but our operations associate at Rescripted, she was having some unusual pelvic pain for a couple of weeks, months. She kept being told that it was probably ovulation pain. And because she had ovarian cancer in her family, she ended up being really persistent and she had an ovarian tumor, ended up having, and she's 24 years old, ended up having to get her ovary removed. But I think the moral of the story is like your body and better than anyone else. And if you do have a family history, just remain diligent.
Yes, family history is a big one, right? And family history, if it's significant enough, can lead to genetic testing. And there are some genes that are associated with ovarian cancer that if you do carry those, then there are other major considerations that need to be taken into account. But if you're feeling pain or discomfort, don't let anyone tell you that's normal, because if that's a change from your baseline, then that's worth investigating.
Absolutely. So mammograms, this has been top of mind for me recently, actually through my genetic screening through IVF. One of the silver linings of IVF, of course, I found out I have the ATM gene. So it's not BRCA, but I'm a carrier for this genetic disorder that doesn't influence my children unless my husband is also a carrier, which he's not, but it makes me more susceptible to breast cancer and ovarian cancer. So I've been doing some digging into that, and now I'm going to get my first mammogram at the end of the month when I turn 35. So just like knowledge is power, and now I can get early screenings and stay on top of it. But what are the guidelines for mammograms for someone who might not have any sort of genetic component?
Yeah. So again, you don't know you have a genetic component until you do the testing. And the first thing you want to look at is the family history. If there's no family history of breast cancer, really the first mammogram tends to happen at age 40. And from there, it's yearly. Now, if you go to the gynecologist, you're complaining of breast pain, you're 36, you feel a lump, chances are you're going for a mammogram, right? Mm-hmm. But the screening is recommended. The most strict screening starts at 40. Now, if you have a family history, let's say your mom or your sister or your mom and your grandmother, that the youngest person that what diagnosis was made, let's say at 41, then you would want to start screening 10 years earlier, just so that you make sure that you can catch it early enough, because you are technically at higher risk. Yep. So it really depends on family history if you're going to deviate from your regular screening guidelines.
And do you ever require mammograms before fertility treatments?
Yeah, it is a requirement. Patients don't have to do it if they don't want to. They would have to basically waive that. But it is recommended strongly, because this is one of those situations where if you catch it before you're pregnant, you can still make embryos, freeze them, handle the situation with the abnormal mammogram or baby breast cancer, and then return to the fertility aspect. But if you're pregnant and you're at a stage of the pregnancy where you're far from delivery and they're telling you need immediate treatment, now you're stuck with a very difficult situation. You don't want to be in that situation.
Absolutely. Actually, speaking of that, there's been a lot of, I guess I can call it misinformation in the media about a connection between IVF and cancer. Can you speak to that a little bit?
Sure. I think based on what we know as a field and some of the studies that have been done, I personally don't think it's very clear. A lot of the attention has been placed on breast cancer or maybe colon cancer or ovarian cancer. And I think the data, if there's any, is more towards this kind of benign or low malignant potential ovarian tumor that could potentially be associated with the use of the injectable medications. But at the same time, there are other studies that were quite large that showed it was the diagnosis of infertility that led to that increased risk, not necessarily the use of the medications. Maybe the inherent cause of the infertility is what's increasing the risk of this particular ovarian cancer. And there's really insufficient data to suggest that breast cancer is a direct result of infertility treatments or colon cancer. So that's as far as I know where we are in terms of cancer and risks from IVF treatments.
Have you had patients that were concerned about that?
Oh, yeah, all the time. I get that question all the time. Absolutely.
Yeah, it's definitely nerve-wracking, but you got to look at the research and weigh the risk benefit.
Of course. That's right.
For sure. What else? You touched a little bit on Oncofertility, but there's so many amazing options now for young cancer patients that can help them preserve their fertility. So can you dive into that a little bit? What are some options? Egg freezing. I know we also talked about ovarian tissue cryopreservation. Can you go into some of those treatments and how they can help cancer patients in the long run?
Absolutely. This is actually an interest of mine. And we see a lot of this. We see cancer patients all the time. And the question is, what can you offer in a timely manner that will not decrease that will not decrease the chances of having successful chemotherapy, for example. So you don't want to get in the way of the oncologist. And in many situations in the past, particularly, oncologists really didn't want to deal with the fertility aspect because they really wanted to start treatment right away to increase the chances of survival. And it wasn't until egg freezing became more mainstream and successful that we started to see a lot more of fertility preservation for 30-year-old women who had, let's say, melanoma or lymphoma, breast cancer. So in these cases, we were able to develop protocols that would allow us to very quickly freeze eggs or even embryos, if they wanted to, without having to necessarily wait for them to start their period to then go through a 2-week process of freezing eggs. So they would get the diagnosis, they would call up a clinic. Most clinics you call them up and you have cancer, you need to preserve your fertility, you're getting into that clinic in the next 24 hours for a consultation. Right. And then from there, wherever you are in your cycle, you're starting injections and you're doing the egg freezing process within 2 weeks. And that's become very efficient. And in some cases, some cancers allow a little bit more flexibility. So you're able to even do more than one egg freezing cycle. So that really just depends on the oncologist, depends on the cancer, depends on the comfort level of both the patient and the doctor treating them. Then let's say you have a very aggressive cancer and the oncologist wants to start chemotherapy in 4 days and there's no ifs, ands, or buts about it. What do? You cut eggs in 4 days. I think, if I'm not mistaken, and I don't know this off the top of my head, but I believe it was 2018 or 19 that ovarian tissue cryopreservation really left the experimental box and became something that is a little bit more acceptable and could be potentially a standard of care for cancer patients. And the way that works is that you're actually taking out either a whole ovary or a half ovary, and you're taking out the whole ovary and you are actually processing strips of that ovary. Typically, you can get about 20 to 30 strips per ovary. And each one of those strips has 1,000 plus eggs. So you're able to freeze these strips that then have a tremendous amount of eggs that you could potentially reimplant into a patient who's in remission and has been cleared by the oncologist to get pregnant. And the thing that's interesting about that is if there's no other issues, why can't that patient then get pregnant naturally? That's very exciting, obviously.
That's so, I don't think I've ever visualized that. So could that be like the future of egg freezing?
It's to drive that point, when you're actually processing the tissue in the dish that you process the tissue, there could be 50, 100, 150 immature eggs in that dish on top of the tissue you just processed. And then you take those eggs and you can actually mature them in vitro, right? And then you can freeze those eggs as well on top of the ovarian tissue.
Wow. And how do they then mature outside of
the human body?
In the womb.
Sure. So there's actually specialized media that has all the necessary, or just what we think are the necessary elements to help an egg progress from an immature stage to a mature stage. Mm-hmm. But even when I was training as a fellow, my research project involved immature eggs that were essentially being discarded because they weren't freezable. And I would take those eggs, and I didn't do anything special. I left them in regular media, and I would take pictures of them every 5 minutes for almost 48 hours. And 50% of those eggs actually matured on their own in regular media. And I actually had videos of the eggs wiggling around, and you can see them going through the different stages of maturity. That was an interesting kind of side effect to what I was actually looking at. So yeah, the in vitro maturation of eggs is something that is very possible, and there is specialized kind of expertise and equipment and that is used for that purpose. And even in places like Korea from years ago, they were doing this for patients who had PCO, and they didn't want them to get hyperstimulation syndrome. And they would stimulate the ovaries, and they would get the eggs out way before they were mature, and they would finish the process in the dish.
Wow.
So that's where little steps at a time, we move our understanding forward and the science moves forward.
That's what I love about this field. It's at the end of the day, IVF's only been around for 42-ish years, and advancements every single day.
Correct. That's right.
Amazing. Any other thoughts on preventative health? Is there anything I missed?
No, I think that we touched on everything. Again, it's really important that when you're thinking about undergoing fertility evaluation treatment, or even just getting pregnant, there are things that for some reason are just not part of the normal conversation. For example, you mentioned you were going through the process and you found out you carry ATM. I don't think it's such a bad idea for partners to go and get their genes tested before they even try to start naturally, right? Because
agreed, yeah.
And all that falls under the preconception counseling kind of umbrella. And OBGYNs should and do feel comfortable going through that. And I think that's something that a patient should ask. Hey, thinking about getting pregnant in a year, should I do genetic testing? Should I do my ovarian reserve testing? Is there any point in checking if my tubes are open before I even try? These are conversations that should be had, I think.
And that's so much a part of why Rescripted exists, because when I was on my journey back in 2017, I felt like so much of everything I was learning along the way was like reactive versus proactive. It's why, or hindsight was 2020, and it felt, why didn't, even like the conversation about how many kids you want to ultimately have. I felt after many failed IUIs that I wish someone had just asked me how many kids I wanted to have and told me that IVF might actually be the best route for me, because then I would have embryos in the future. All these conversations that you don't think of having because you don't know what you don't know, but at the same time, knowledge is power.
Oh, yeah. And I think you're absolutely right. That's actually one that's very interesting, because when I first started as an attending, I was seeing patients that they got pregnant on IUI at 38, 39. They'd have a child. The child keeps you up all night for 2 years. You're not really thinking about it unless you're like really focused on having 2 or 3 kids. You might decide when you're 41, 42, hey, you know what? I want another child. And what should have been discussed when you first got pregnant with IUI was, if you have any consideration that you might want a second child, even if you don't necessarily use the embryos right now, freeze some embryos so that you can be a little bit more secure when you come back.
Same thing with egg freezing. I'm like, without directly pushing it on anyone, I'm like, single friends, please freeze your eggs.
Of course. And I think that's great. I wish more people were doing that.
Yeah, because just having options is powerful, and not feeling, because at the end of the day, as much as you want to say, I'm still young, I have time, it's like fertility is somewhat time sensitive. So
it is. You're absolutely correct.
It does play a role, even though you don't want it to.
Of course.
This was awesome, Dr. Kofinas. I learned so much, and I'm sure everyone else will as well. So I appreciate it. And until the next episode.
Thank you, Kristen. I appreciate it as well. All the best.
If this podcast means something to you, be sure to hit follow or subscribe. This helps you because you'll never miss an episode, and it helps us because you'll never miss an episode. For science-backed women's health content that meets you exactly where you are, head to Rescripted.com or follow us on social at Hello Rescripted.